Wala pala. Tayo ko paliwanag. Nandito.
Good morning. Okay. So we will have our biochemistry reporting for this morning. So we will have 3 groups. So we will have one topic on iron deficiency, one on carbon monoxide, and the others, what did you choose? Sickle cell or thalassemia?
Thalassemia po, Doc.
Thalassemia. Okay. So good morning, Dr. Arca.
Good morning.
Okay, let's start with the first group.
Wait lang po, Doc. Okay na po yung slides.
Yes, go ahead.
Yeah.
Okay po. So good morning to everyone. We are the first group and we will be reporting on carbon monoxide poisoning in the 21st century.
For the abstract, next slide, please. Next slide, please. So the world has experienced some very large shifts in the epidemiology of carbon monoxide poisoning, but it remains one of the most important toxicological global causes of morbidity and mortality. So the diagnosis confirmed with blood gases such as pulse oximeters and the lack of both sensitivity and specificity. So several strong predictors for serious neurological sequelae are the prolonged loss of consciousness and elevated S100B and the reduced life expectancy. So for this journal, the elevated troponin are now reasonably well established. And despite this clearly defined high risk group and extensive research into the pathophysiology, there has been little translation into better treatment. And much of the pathophysiological research has focused on the hyperbaric oxygen, which is a therapy that increases the amount of oxygen to your blood that your blood can carry. And it is apparent that the clinical trials show little evidence for the benefit from the hyperbaric oxygen. And the most recent even raises the possibility of harm or repeated courses. So more logical and promising potential antidotes have been under research, although recently both animal and small human studies suggest that erythropoietin, or the hormone from the kidney that stimulates the red blood cell production, may reduce the S100B and prevent neurological sequelae. So the S100B, this is a marker of brain damage, and it stands for the S100 calcium binding protein, so protein of the S100 protein family. So the major breakthroughs are likely to require further research on this and other treatments that may inhibit post-hypoxic inflammatory responses and apoptosis.
We go on to the mechanism of toxicity. So your carbon monoxide binds to hemoglobin, which then forms a complex carboxyhemoglobin. Within the red blood cells, when hemoglobin is exposed to carbon monoxide, subsequently binding to hemoglobin with an affinity of 200 to 240 times that of oxygen. Carboxyhemoglobin reduces the carrying capacity of hemoglobin for oxygen, which impairs the release of oxygen to the tissues and results in hypoxia. Another mechanism is we see carboxyhemoglobin as a chemical asphyxiation, wherein your carbon monoxide binds to cytochrome C oxidase, which is found in your complex 4 in the electron transport chain. This then results in the impairment of ATP synthesis and increased production of reactive oxygen species. Therefore, there's no ATP synthesis, which then affects the organs with highest oxygen demand, making it most susceptible to injury, such as our brain and our heart. So injuries such as neurotoxicity and cardiotoxicity appears, such as Parkinsonism and memory and concentration impairment. For cardiotoxicity, we have your myocardial injury and reduced life expectancy. So as we have observed an anemia, and especially during high altitude, there is a compensatory mechanism that our body does to supply oxygen to prevent hypoxia. It also happens during carbon monoxide poisoning. To maintain oxygen delivery to the brain, a large compensatory mechanism, increase in cardiac output is required. Rise in cardiac output and respiratory rate also greatly accelerates carbon monoxide uptake. At a critical carboxyhemoglobin and time point, which likely varies considerably between individuals, the heart becomes unable to deliver a cardiac output great enough to compensate for the reduced oxygen carrying capacity. Cardiac hypoxia will reduce cardiac output and exacerbate severe tissue hypoxia, and death will rapidly occur. So as we can observe here, in the first graph, this is the oxygen delivery and cardiac output on carboxyhemoglobin. So first off, there is a linear progression in the cardiac output and the carboxyhemoglobin. And as the patient or as the person is exposed more to the carbon monoxide, being it a gas, the next graph shows that there is more carboxyhemoglobin or carbon monoxide rather than the compensatory oxygen mechanism. So the body won't be able to compensate for the large concentration of carbon monoxide in the body. That is why usually those people that are exposed to high concentrations of carbon monoxide, their cases leads to death.
For the long-term sequelae and prognostication, normally the long-term consequences in survivors, it ranges from mild to severe brain damage. And it's divided into two, which is persistent neurologic sequelae and delayed neurologic sequelae. On the persistent neurologic sequelae, the symptoms are pretty straightforward, like changes, mood swings, depression, short-term memory, affects attention and concentration. On the delayed neurologic sequelae, it's more severe because it's affected by the watershed infarcts or the ischemic lesion. Declining memory, it's not immediate but observed after initial recovery. The ratio is lower than the persistent neurologic sequelae. Incidence of neurologic sequelae depends on the definition applied, severity, and timing of the assessment. Neuropsychological testing may be useful to provide objective measures of subtle deficits not found with routine bedside mental state examination and to monitor the progress of this sequelae. Long-term follow-up is needed to those at risk since subtle defects can be developed or become apparent over a few weeks to months. The best identified risk factors for long-term neurological effects are those who sustained loss of consciousness during carbon monoxide exposure. Other factors, repeated exposure and old age. Majority of the cases symptoms gradually resolve over the few weeks, months, and return to full-time work. Next one. Study to date uses two markers to measure brain injury, the neuron-specific enolase, or the glycolytic enzyme that is primarily localized in a neural cytoplasm in the central nervous system. 2S100B, it's a calcium binding protein localized to astroglial cells. They are both released after hypoxic damage as a result of neuronal and astroglial cell death. High level of S100B serum, if it's more than 0.165 microgram per liter. NSE have shown a less relationship to severity than S100.
So for the toxicity assessment, next slide, please. The severity of carbon monoxide poisoning is due to the following. First, you have the duration of exposure. Second, the ambient concentration of carbon monoxide. Now, the concentration of carbon monoxide is measured through the venous carboxyhemoglobin levels in the blood. And lastly, the underlying health status of the exposed individual. Next slide, please. So to measure the carbon monoxide concentrations in the blood, we have your non-invasive pulse oximeter device. This device is used for rapid field measurement and monitoring. However, the device is still in its early developmental stages. It is limited only to situations in which the chronic low-level exposures leading to carboxyhemoglobin levels of less than 15%. Next slide, please. So the standard method in order to assess the severity of carbon monoxide exposure is the focus should be focused on the cardiac and neurological symptoms. So you have your hypoxia, loss of consciousness, and chest pain, as well as cardiac ischemia, which is measured by the electrocardiography ECG changes. Next slide.
And so for the management of carbon monoxide poisoning, which is the initial management is the removal of patient from the source of exposure and administrating oxygen. So for the first one, 100% oxygen through a ventilation. It is said that in 4 to 6 hours of 100% monobaric oxygen could remove 90% of carbon monoxide in the system. Nomobaric oxygen is a routine adjuvant oxygenation intervention supplied by the nasal cannula or venturi mask with 1 atmospheric pressure. The ventilator will help the patient breathe in and out. And for the second is the assessment of severity and potential for coexisting poisoning. This would include 12 lead ECG and electrolyte, full blood count, and COHB carbohemoglobin. And for the supportive care, it is to ensure the airway is maintained in those unconscious patient, quiet and resting comfortably for the patient as to lessen the muscular activity that use up the oxygen and increase the demand of it. When there is a history of related diseases or complication, um, like a sustained loss consciousness or cardiovascular diseases, chest pain, or ECG changes, series of ECG and cardiac enzyme is obtained for further monitoring and assessment per patient. Next, please. And to the main therapeutic goal is to prevent an acute and chronic psychiatric consequence. It is to prevent oxygen toxicity. The said therapy is the hyperbaric oxygen. It is effective of removing carbon monoxide, but the controversy but it has controversy of it ineffective in the said journal. While in the journal, it is said that it was tested in clinical trials. However, more negative result of its effectiveness than positive. Although it was assumed to be useful for prolonged unconsciousness, abnormal neurological sign, cardiovascular dysfunction, and severe acidosis. Hyperbaric oxygen therapy is similar to norbaric oxygen therapy with breaking of 100% oxygen with its hyperbaric chamber compressed to greater than 1.4 atmosphere of absolute pressure with a carbon monoxide half-life of around 4 to 5 hours in normal room air would decrease to an estimate 40 to 80 minutes in this therapy. Additionally, with the increase of absolute pressure to 2 atmospheric pressure, could further decrease carbon monoxide half-life to 23 minutes. But with the 2-hour preparation of the therapy treatment, question the rationale of its given, as it's given the half-life is only 90 minutes with a high flow oxygen. The time it takes for preparing it is more than the amount of CO with a high flow oxygen, making the therapy as a more effective method being limited in practice of removing in the time of the study. But currently, this treatment is well established now and recommended, and it's a recommended treatment for carbon monoxide poisoning. Next.
So for our pharmacological treatment, so our study listed several ways which have been tested and may be used and are deemed safe to use for the management of carbon monoxide poisoning. First, we have erythropoietin. As the name implies, it's a cytokine which is involved in the production of red blood cells. So according to a study, to one research which tested erythropoietin with the placebo, tested on 103 patients with diagnosed with carbon monoxide poisoning, it showed that it significantly decreased S100 beta levels, which is emerging as one of the markers in diagnosing this condition. It also showed significant decrease in animal models, especially in the reduction of neuronal sequelae, as mentioned in the previous section of this report. However, again, it needs to be studied further because in the long run, there were still reported cases of deaths within this area of treatment. So for the next, we have hydrogen-rich saline, which is used in Japan for metabolic disorders. It is non-toxic, convenient, and safe. And according to studies conducted again on rat models, it reduces reactive oxygen species levels and upregulates endogenous oxidative enzymes. So several others, such as granulocyte stimulating factor, nimodipine, fructose 2-phosphate, hyperoxygenated solution, and endaravone are also being studied. Yet, according to this research, it is not yet recommended to be used outside of clinical trials as it needs further development in for its use. So to conclude our report, again, the management for carbon monoxide poisoning is still 100% oxygen therapy in order to treat the respiratory symptoms, which could which if not treated, would further progress into uh, into what do you call this? That would further progress in that would further regress into hypoxia, and it could further affect uh, the it would further increase the neurologic symptoms, if I may say. And of course, we need to identify the high risk patients. For example, those with asthma or other conditions that would affect the respiratory and the nervous system. And identifying symptoms still most especially the loss of consciousness. And apart from this, in the development, S100 beta levels as biomarkers are showing potential, and the hyperbaric oxygen, while it remains one of the most uh, ideal treatment for this condition, there are still studies being made, yet its use somehow is still unclear, no? And the pharmacological treatments, as presented earlier, have strong biological rationale, but again, it still needs further studies in order for it to be deemed as potential or ideal, rather, ideal treatment for this condition. And that ends our report. Thank you very much.
Thank you very much, Group 1. That was a interesting article and a very straightforward one. Question, how do you measure the S100 beta?
Blood test po, Doc.
Blood test, okay. All right. Is it routinely done or just in special cases like this one?
As special cases po, Doc, because sometimes after 6 hours of exposure, pwede po siyang bumaba. But then later on, tumataas rin po siya. So it needs to be done routinely after a few months of recovery.
After recovery. So is it's more of monitoring.
Yes, Doc. Sometimes po, it takes months, a couple of months before the brain injury progress. So that's why they need to do it like from time to time or for monitoring.
Okay, so again, what does the SB100 beta what information does it give us for the benefit of the group?
It will show, sorry.
Go ahead.
For the S100 data, it will measure the level of the brain injury. Since the S100B calcium, it's a protein that will be released by the astroglial cells once there's a hypoxia or brain damage. So if it's hypo, then that means there's a brain injury.
All right. So in the management, you measured pharmacological measures that can be done. So what is the role again? Can you reiterate the role of the erythropoietin in carbon monoxide poisoning?
And so, Doc, according to the study, the erythropoietin offers neuronal protection, and it showed that it decreased stroke scores, and there was a significant decrease in the amount of S100 beta levels.
But in general, what does erythropoietin do?
Doc, it's for the production of red blood cells po, erythropoietin from the name itself po.
So it stimulates red blood cell production, and it is produced where? I mean, the erythropoietin.
In the bone marrow po, Doc.
No. The blood is produced in the bone marrow. Erythropoietin is from where?
In the kidneys po, Doc.
Kidneys, yeah. So it's not mentioned in the study, no, but monitoring of the kidney function would also be helpful, no, because if erythropoietin is essential in the survival of this patient, then monitoring the function of kidneys, no, would be helpful too. Okay, so what are the disadvantages of the hyperbaric treatment aside from long preparation? By the way, that is available in our hospital. No? There's a chamber, the hyperbaric chamber already. That's
the disadvantages po, with the pressure po, it increases the middle ear injuries. There's also temporary nearsightedness that may be caused by the hyperbaric treatment po.
And the lungs, what does it do?
The lungs may collapse po because of the influx of high pressure po.
Yeah, that's one of the more common complications as well. Okay, so when there is carbon monoxide poisoning, what happens to the oxygen dissociation curve? You mentioned in passing in the pathophysiology of carbon monoxide poisoning. So what happens to, it's it's an inhibitor to oxygen binding, right? So what happens now to our oxygen affinity? So, okay, let's make it simple. Will your oxygen dissociation curve be shifted to the left or shifted to the right in the presence of carbon monoxide poisoning?
During carbon monoxide poisoning, your oxygen dissociation curves shifts to the left.
So meaning when it shifts to the left, what happens?
It is indicative that there is less oxygen that is available on the tissue.
Yeah. So what, because basically when it is shifted to the left, you harbor more oxygen, right?
Yes.
Then
Yes.
and when it's shifted to the right, you tend to release more oxygen into the tissue. All right. Are there any more questions? Dr. Andres, do you have questions or from the rest of the class?
What's the limit? Promising the carbon monoxide non-invasive measurement, because as you can see, current measurements of how we measure or diagnose carbon monoxide, it's currently symptomatic, okay, and ECG. And what would ECG tell you? You already have changes. You are already at the, if you are looking at the levels of care, you are at the tertiary part. Okay. Non-invasive or could be at least a secondary or a primary level intervention wherein you detect it earlier such that you have no symptoms yet and you can detect when your carbon monoxide levels are at a toxic um, level. However, again, what are the situations that you get carbon monoxide poisoning? You are really trapped inside, for example, a room wherein there is sequestration or there's lack of oxygen. Okay, good job. No more questions. Let's have the
Yeah.
next group.
Thank you. Thank you, Group 1.
Thank
Thank you,
you,
Doc.
Dad.
One last comment pala. The article was made in 2014, no? So that was around roughly 8 years ago. So maybe the recommendations and management here have also been updated. Mm. Right, like next group. Thank you, Group 1. Very good.
Ano po, kita po ba yung screen?
Yes, visible.
Hello, can you hear me po?
Yes.
Okay, good morning, Dr. Andres and Dr. Arca. We will be presenting about thalassemia. Next slide. So our table of contents are as follows. Okay, next slide. For the objectives, next slide. First, we'll summarize the etiology or disease, clinical manifestations of thalassemias, then review the different laboratory and bedside evaluation techniques for the management of thalassemia patients, then outline the treatment and the management options available for thalassemia, then determine the complications that may arise due to thalassemia, and then identify interprofessional team strategies for improving care, coordination, and communication to improve patient outcomes in thalassemia. Next slide. So, what is thalassemia? Thalassemia is an autosomal recessive condition, meaning that of which the parents should be affected or are carriers of the said disease. It is a genetic disorders, and it is a disorder via mutations in the globin gene, specifically chromosome 16 and chromosomes 11. This results in decreased synthesis of alpha and beta chains of hemoglobin, and this causes anemia. There are different types that determine depending on which globin genes are mutated. As said, we have two alpha and beta. Next slide. So in the alpha thalassemia, this is caused by alpha globin gene deletion, while beta thalassemia results from beta globin point mutations. So in beta thalassemia, we have two other subtypes. We have the beta thalassemia minor. It is a heterozygous mutation, meaning that there is only one gene affected. And beta thalassemia major is homozygous, meaning that both genes are affected. Next. So clinical manifestations for alpha thalassemia, the most severe would be your 4 allele deletion. This usually is incompatible with life and results in hydrops fetalis, or a condition in which there is fluid buildup in the baby's organs. And one allele deletion is usually the clinically silent or the asymptomatic type. The beta thalassemia minor is the mild or asymptomatic version of beta thalassemia, and this only includes one beta globin gene missing, while the major or the Cooley's anemia is usually more severe, have severe symptoms and complications such as this jaundice, growth retardation, hepatosplenomegaly, endocrine abnormalities. This is caused by the complete absence of your beta chains. And this also displays severe anemia, that of which may require lifelong transfusion for the patients. Next.
So we evaluate thalassemia using several laboratory tests. First is the complete blood count, and this is actually the first investigation when we suspect a case of thalassemia. It will show a low hemoglobin and a low MCV, which is the first indication of the disease. This is after ruling out iron deficiency as the cause of the anemia. Next, we have the peripheral blood smear. This is the assessment of the red blood cells properties. Thalassemia can present with the following findings on the peripheral blood smear. First, we have the microcytic cells or low MCV. This will show you the size of the red blood cells, which appears to be smaller compared to the normal. Next, we have the hypochromic cells. You will indicate it indicates the less colorization of the blood cells. Next, we will have the variation in size and shape, namely anisocytosis and poikilocytosis respectively. Next will be the increased percentage of reticulocytes. Reticulocytes are the precursor of red blood cells, and we will see an increase in percentage if in response to low hemoglobin. Next will be the target cells, and lastly will be the Heinz bodies.
So the next part for the evaluation or the test done for thalassemia would be iron studies. Iron studies are done to rule out iron deficiency as anemia as the underlying case, underlying cause of thalassemia. Next would be erythrocyte porphyrin levels may be checked to distinguish an unclear beta thalassemia, and is a minor diagnosis from iron deficiency or lead poisoning. Next would be DNA analysis. Subsequent DNA analysis will give a definitive diagnosis for thalassemia. Point mutation detection in beta thalassemia allele and large deletion detection for alpha thalassemia.
Next would be biochemical tests, which would include your abnormal hemoglobins. The thalassemias result from defective globin chain production. Hemoglobin tests measure the types of hemoglobin in a blood sample, and people who have thalassemias have problems with the alpha or beta globin protein chains of the hemoglobin, as mentioned earlier. Next slide.
So for the treatment and management of thalassemia treatment depends on the type and severity of the disease. For mild thalassemia, these are patients with hemoglobin level of 6 to 10 grams per deciliter. So signs and symptoms are generally mild with thalassemia minor, and little, if any, treatment is needed. So occasionally, patients may need a blood transfusion, particularly after surgery, following childbirth, or to help manage thalassemia complications. So for the moderate to severe thalassemia, these are patients with hemoglobin level less than 5 to 6 grams per deciliter. Frequent blood transfusion is needed. The goal is to maintain the hemoglobin at around 9 to 10 milligrams per deciliter to give the patients a sense of well-being and also to keep a check on erythropoiesis or the formation of red blood cell from the bone marrow and suppress extramedullary hematopoiesis or the formation and activation of blood cells outside the bone marrow. Um, Next treatment is the chelation therapy. So due to chronic transfusions, iron starts to get deposited in various organs of the body. So iron chelators such as the ferracirox, the ferrosamine, and the ferriprone are given concomitantly. When you say concomitantly, these drugs are given simultaneously to remove extra iron from the body. Next slide, please. Another treatment is stem cell transplant. Stem cell transplant or bone marrow transplant is a potential option in selected cases, um, such as children born with severe thalassemia. The advantage of stem cell transplant is it can eliminate the need for lifelong blood transfusions. However, there are some disadvantage such as graft versus host disease, chronic immunosuppressive therapy, graft failure, and transplantation related mortality. Um, Another treatment is gene therapy. It is the latest advancement in severe thalassemia management. It involves harvesting the autologous hematopoietic stem cells or HSCs from the patient and genetically modifying them with vectors expressing the normal genes. These are then infused to the patients after they have undergone the required conditioning to destroy the existing HSCs. The genetically modified HSCs produce normal hemoglobin chains and normal erythropoiesis ensues.
So next treatments are includes genome editing techniques like zinc finger nucleases, transcription activator like effectors, cluster regulated interspace short palindromic repeats, with CAS9 nuclease system. Splenectomy, this is to limit the number of required transfusion. Usual recommendation when the annual transfusion requirement increases to or more than 200 to 220 ml RBCs per kilogram per year with a hematocrit value of 70%. This controls the spread of extramedullary hematopoiesis. Post-splenectomy immunizations are necessary to prevent bacterial infections, including pneumococcus, meningococcus, and Haemophilus influenza. Post-splenectomy sepsis is possible in children, so this procedure is delivered until 6 to 7 years of age, and then penicillin is given for prophylaxis until they reach a certain age. Next. So, cholecystectomy. Patients can develop cholestasis due to increased hemoglobin breakdown and bilirubin deposition in the gallbladder. If it becomes symptomatic, patients should undergo cholecystectomy at the same time when they are undergoing splenectomy. Diet and exercise, like drinking tea aids in reducing iron absorption for intestinal tract, giving of low quantities of vitamin C along with iron chelators, deferoxamine. People with thalassemia are prescribed also with supplemental vitamin B9, known as folic acid, to help treat anemia. Folic acid can help red blood cells develop. Treatment with folic acid is usually done in addition to other therapies. Next.
So further complications that may arise due to thalassemia would be iron overload due to increased blood transfusions from the sickness itself, damaging your heart, liver, and endocrine system, which regulate the processes of iron throughout your body. Um, Patients with thalassemia have increased risk for infection, especially with the removal of your spleen and or other important organs. Bone deformities such as expansion of your bone marrows and widening of your bones due to the abnormal bone structure. This would be more prominent in your face and skull, as well as making your bones brittle. The enlargement of your spleen, which helps your body fight infections and filter unwanted materials, such as old or damaged RBCs. Thalassemia is often accompanied by the destruction of large numbers of RBCs that will make your spleen work even harder. Stunted or slowed growth rates, it slows down or delays puberty of children, and heart problems such as CHF and abnormal heart murmurs can be seen in severe thalassemia. Thank you.
Hello, good morning. So this is the last part of our presentation. I'll be discussing a few strategies to further improve the healthcare outcome of the patients suffering from thalassemia. But before I move on, I would just like to summarize the previous presentation of my group mates for emphasis purposes. So far we know that thalassemia is an inherited blood disorder which causes the body to have less hemoglobin than normal. So since hemoglobin enables red blood cells to carry oxygen, that means that patients with thalassemia may constantly feel fatigue. And then some of the common lab tests that can be utilized to screen and diagnose the disorder would be the complete blood count, peripheral blood smear, and also DNA analysis. One of my group members also discussed a few management for thalassemia, which includes blood transfusion, chelation therapy, and stem cell transplant. So again, my part would be to discuss the different strategies to improve healthcare outcomes. Obviously, we expect medical specialists like cardiologists, hepatologists, but also endocrinologists, psychologists, and psychiatrists for management of for emotional support, perhaps having social, let's not forget, of course, the support of nurses as well. Having social support will be integral in the management of thalassemia. So we have family and friends for that. They can serve as the patient's strong support system. If the patient has no people, has no family or friends for some reasons, the social worker can help provide that support. Or sometimes the social worker can also assist in ensuring the patient's financial resources. So to help the patient connect with some non-governmental organization for financial resources. This means that social worker would be supposedly an integral part of the patient's hospital care. Unfortunately, that's not always the case. Another additional aspect that can help in the healthcare outcome of the patient would be patient education. So aside from doctors, nurses may also educate the patient, say on the importance of the treatment of compliance to avoid serious complications that were mentioned by Paulo a while ago. Then we have preventive measures as well. This could be in the form of prenatal screening, say in pregnant women, sometimes in young children as well, because they limit. This is an effective strategy to limit the disease morbidity. Geneticists may also help in some parts of the world. What do you call that? In some parts of the world, there are restrictions on issuing marriage licenses for two people with the same disease. So basically, that's the end of our presentation for thalassemia. Thank you.
Thank you, Group 2. Dr. Andres, do you have questions?
With regards to prenatal screening, what is done? And why do we need to do prenatal screening? What particular thalassemia are we looking for? And what particular complication are we wary of? Because as you can see, as you have reported, thalassemia would manifest later in life. Okay? Sometimes it's very mild. But I do agree you pass it on because it's genetic. You pass it on to your offspring. So why do we do an invasive right now? All monitoring or for prenatal screening would be invasive in the form of chorionic venous sampling. But why do we need to do it in patients with thalassemia? What are we wary of? Have you encountered with your readings?
Ano po, doktora? Alam ko, since nag-duty po ako bilang. Alam ko, doktora, yung sakit na yan nagpapas po sa placental barrier ng bata. So it might be from the amniotic fluid and could cause parang, I think, coolie anemia ba yung tawag doon, doktora? Kapag ka nag-mutate yung beta hemoglobin ng bata sa loob ng mom.
Hindi ganun yung hindi ganun yung mechanism niya, Paolo. Oo, hindi siya nagpa-pass. Oo, hindi siya nagpa-pass through sa kasi nga it's genetic.
Genetic, remember.
So hindi siya because nagpa-pass sa barrier. Oo.
So sige.
That's a very good question from Dr. Andres. That's a very big concern.
2 alpha and you have of the 2 thalassemias, which would produce more complications?
Hello po. Beta thalassemia po would produce more complications.
Okay, Miguel, can you refresh us again with the subtypes of the thalassemias? Then we'll go back to Dr. Andres'
Keton.
question kasi magandang question yun eh.
Hello. So, bale po, ang alpha thalassemia is caused by alpha globin gene deletion, while beta thalassemia results from beta globin gene point mutations. And dalawa po yung under sa beta thalassemia, which involves a heterozygous mutation or a homozygous mutation, which are minor and major respectively.
Ayan ang sagot to.
Yan, nandito yung sagot. Actually, Paolo, there are 4 types actually kasi depending on the number of gene deletions. So kung 1 deletion lang, 2 deletions, then that's milder form for beta kasi pwede siyang either carrier, no? Or trait. Kung 1 gene lang, the carrier lang siya. Or kung 2 genes, trait lang siya. So it's, and as was mentioned earlier on by one of your classmates, no? So mild anemia lang yon, no? So rarely do they require transfusions. Pero pag 3 genes and up, yun yung mas madalas na yung, mas lalim na yung anemia nila. So now it depends on alpha or beta, no? So here, pagka 3 gene deletions, what happens to your alpha and ano na ngayon yung beta mo? Okay, kung we have 3 gene deletions na, yan, para ma-answer natin yung question ni Dr. Andres. So mas malala ba siya? Or mas mild siya kung 3 gene deletions?
Mas malala na po, Doktor.
Okay, oo. So, sa beta thalassemia, if there's 3 gene deletion, that's intermediate already, no? So, mas madalas na yung transfusion. But compared to a 4 gene deletion, which is ito yan, yung major, thalassemia major, yan yung talagang tinatransfuse, no? Minsan, monthly, we have patients na 2 weeks pa lang nagtatransfuse na ulit because talagang hindi na nagpo-produce ng normal blood, no? But with alpha thalassemia, pag 3 gene deletions, what happens?
Ano po, Doktora? Hemoglobin H?
Yes, so severe na siya. And it is equivalent to the thalassemia major of your beta thalassemia. Gan, yung severity niya is like the 4 gene deletion in beta. Now, what happens if there are 4 gene deletions in your alpha thalassemia?
Ayan na po, Doktora, yung hydrohospitalis.
Yon. So now, ano yung sagot ninyo sa question ni Dr. Andres? Why do we need to have that invasive procedure, no? Prenatal screening?
Siguro po to predict po which type of thalassemia po would be possibly affecting this child po and plan for future treatments or procedures.
Yung type of thalassemia you can already somehow guess because you can test the parents, diba? So you will know what are the defects, the globin defects in the parents. So you will know already what to predict sa bata. Diba?
I think, Doktora, kasi hindi po nag-show yung prominent signs and symptoms. So that's why we have to do yung either CVS or amniocentesis sa kanila. So we can further check, diba?
Okay, so aside from checking, no, so to go back to Dr. Andres' question kasi very anong question ano pang significance nun aside from checking kasi if both parents are, say, both have thalassemia, alpha thalassemia, then you can, by doing your ang tawag doon, 'di ba yung gene pairing that we get pag kino-compute natin, you can already predict the outcome of the baby. Lalo na kung pareho silang several homozygous. So you can predict already that the baby may have 4 gene or 3 gene deletion. So aside from knowing or diagnosing, what else is the significance of doing that?
Hello, Doctora.
Yes, Hafsa.
Probably to assess for the risk of the pregnancy and of course to see if the baby's survival rate would be high or low.
But you can do that. You can do that assessment even without doing the invasive procedure. Ano pang naisip nyo na pwedeng gawin? Why go to that length? Kasi hindi yun madaling gawin, di ba, Doktora?
Yeah.
Oo. May na-observe ako once lang na they did that. Nang toxic talaga. Lahat sila on their toes. Yung mga OB sobrang toxic doing that. So ano pang pwedeng ginagawa? Bakit siya kailangan gawin? Aside from diagnosing. Say the parents have, the mom is a known alpha thalassemia and had several miscarriages already. And then pregnant again. Why would you propose doing that prenatal procedure?
Hindi po, Doktora, kasi dahil sa kanyang thalassemia, that's why yung intrauterine lining niya nagkakos ng miscarriage. That's why you have to do it para to prevent future miscarriages from the family.
I don't know. I will ask Dr. Andres. Nagkakos ba ng miscarriage yung lining?
Hindi naman, but it's a difficult procedure and that would also be a risk. Especially we do it early you do it first trimester, and you will eventually learn that in obstetrics you will do all procedures unless it's very vital after the first trimester. And this chorionic venous sampling, by the way, which will not only detect for thalassemia but also other genetic diseases, is done at 10 to 12 weeks. And it's a very high-risk procedure, but still, why is it still being done? Because there would be a lot of, again, if you do any procedure, you always look at benefits outweighing risk.
Ako po, Doktor.
For example, if we focus on thalassemia, hydrops fetalis, sabi nga namin dyan, laging hydrops fetalis yan because you have a low chance of survival. Because you have a swelled fetus. If ever the fetus survives, it would also be a morbidity or a perinatal, neonatal, under one mortality. So it would really be a fatal outcome. That's why we need to detect, or as early as you see your both of your parents both with thalassemia and you see high risk or 3-4 deletion, you counsel already that you prevent pregnancy or advise to avoid pregnancy. But again, we meet patients, Doktora, kahit isa. Baka naman, Doktora, pwedeng mag-pair yung out of the how many pairs, yung hindi magiging they would risk that they would go for the chance, even if it is small. Kahit sabihin mo, for ease of computation, 75% would have thalassemia, 25% would not. They would still gamble for wanting to have an offspring, even if you counsel. So sometimes it really does happen. It really does happen.
Mhm. Mhm. And another thing, you can intervene. Dr. Andres, at what gestational age is it advisable to do the intrafetal transfusion? Because when I was a fellow, I was able to observe one in PGH.
Dito mga
Mm-mm.
bumaba na ata parang mga 28
28
for
weeks.
sure.
Kasi parang that patient, parang if I remember correctly, fourth or fifth pregnancy na. All the others were hydrops fetalis eh. And this
Hydrops.
one, they really fought for it eh. So intrafetal, baby, nasa loob pa lang siya, they transfused blood on the baby para lang mag-survive. Oo. So that's one of the reasons why they try to access the baby, no, intranatally, perinatally, sorry. Oo, so
Okay.
to intervene as well.
Yeah.
Mm.
In short, you only do, especially if it's invasive, you only do invasive diagnostics, okay, class, if you can do something about it. Okay, meaning, if you detect it early, you can intervene early and thereby change the course of that pregnancy, in our case, or change the course of disease progression. Okay?
Mm-hmm. Okay. Thank you, Dr. Andres. May question ako for Maynard. Maynard, you mentioned yung labs, no, that are being done. You said CBC, you see hemoglobin and MCV that's low, but you also mentioned hypochromic cell. So what part of the CBC would show you hypochromic cell? Oh, this is part of the CBC result that is always neglected eh, hindi pinapansin. So if you look at the size of the red blood cells, then you look at the MCV. But if you look at the color, meaning yan, hypochromic, maputla, anong titingnan mo sa CBC mo? Any members of the group can answer. Pero si Maynard, report ni Maynard yun. Okay. So ano ba kasama ng MCV? Ha? Sorry?
Is it the hemoglobin po ba?
No, the hemoglobin, yun yung levels that you get. Pero when you are looking at the RBCs, no, you're trying
Hello,
to
Doctor.
describe it. Yes, go Miguel.
Yung MCH po.
Yes, the MCH. So hindi lang MCV at hemoglobin. You look at the ang tawag doon yung red cell indices, no, yung mga hindi natin pinapansin sa CBC result. So you look at the MCV. So in thalassemia and in iron deficiency, they're both low. MCV is low, MCHC is low, RDW is high. No? And then the retic, so kung thalassemia, usually high kasi may hemolysis, right? So again, so para lang sa inyong mga classmates, so what do we mean by anisocytosis and in poikilocytosis? Ano yung description na yan?
Anisocytosis po is what we mean by that is that it's the different sizes po ng mga red blood cells sa smear. While the poikilocytosis po yung sa shape naman po.
Yes, that's true. So pag iba-ibang shapes, then you can describe it as there is presence of poikilocytosis. Okay, thank you, Maynard. Okay. So Mark Joseph, you mentioned that there is a biochemical test that being done for thalassemia. So ano yung usual na test that we do to confirm?
Doctor, a test for hemoglobin po for the blood. To test for
hemoglobin electrophoresis. So we do hemoglobin electrophoresis to measure the different components of the hemoglobin to see if there's hemoglobin F, no, fetal hemoglobin, no, that will indicate the presence of thalassemia also. Okay. So Hannah, you mentioned about transfusion. So when do we transfuse thalassemia patients?
Depende po if mild thalassemia or moderate to severe thalassemia. If
Do
mild,
you question, pag nakita mo yung CBC, mababa ang hemoglobin, do you transfuse right away?
no po.
Why not? When will you transfuse again?
If the hemoglobin po is less than 5 to 6 grams per deciliter.
So you have to wait until it goes down to 5 grams before you transfuse? Okay, I'll help you up. It's unfair. It's an unfair question kasi you're not in the clinicals yet. But if there's something that Dr. Andres and I can teach you, it is you treat the patient, not the labs. No, you may get your CBC result, get a hemoglobin level of 90, but still transfuse. Why? Mataas yon, no? But why? If your patient is symptomatic and if the patient shows continuing blood loss, then you might need to transfuse. But know that physiologically, we can tolerate blood level, hemoglobin levels of 8 grams. No? Okay lang, kaya ng katawan natin yan. But below 7 grams or below, then we start to compensate. No? So yung heart mo magpo-function harder, the other parts of your body would function harder. There are parts of the body which are non-critical that will be compromised kasi of course the blood will be sent to vital organs, right? What are the vital organs again? The 3 very important.
Doktor? Yung liver, spleen, and your heart.
Okay, tama yung isa. Ano pa? Tama yung isa doon. Isa doon sa sinabi mo tama. What are the other 2? Siyempre, hindi ko sinabi kung alin yung tama. Ano pa? Ano yung pag nasira yung organ na to?
Wala na.
Chugi tayo.
Finish na.
Parang
Endgame na.
heart, brain lang.
Okay, tama yung 2. Ano yung isa pa? May isang nawawala.
Heart, brain, liver.
Hindi, may tamang 2. Pwede tayo mag-contest dito.
Kidney po yata.
Hindi, nasa taas ng kidney. Malapit na.
Spleen?
Malapit. Sige. Hindi, medyo nasa likod niya. Malapit na. Sa taas ni kidney.
Hello?
Heart, brain, and nasa taas ni kidney. Nagsisimula sa A. AD. Dulo niya S. ADR, ano? Nasa taas ni kidney. Adrenals. Oo. Pag natsugi yung 3 yun, tapos na tayo. So yun, dun sinesend yung ng body natin yung blood kasi yun yung critical. And the rest of the body, lower, di ba? Kasi so hypoxic na another part. So you transfuse not because of the levels and the CBC levels that you get, but according to you always correlate it with your patient. If the patient is symptomatic, then by all means you transfuse blood already. All right. So si John Rich, okay. You mentioned about splenectomy. Okay, you showed kailan nag-splenectomy because what happens? In thalassemia, what happens to the spleen ba? Bakit kailangan mong tanggalin? Nasaan na si John Rich? Log out na ba siya? Report niyo. Ay, nawala na. Okay. Sige, any group members? So we do splenectomy. Bakit ano nangyari ba sa thalassemia? Ano nangyari sa spleen nila? And sa liver also? Lumalaki, di ba? Mhm. So kung malaki yung liver and spleen, anong nangyayari?
Pagka nagka-splenomegaly po, mawawala yung function niya. And
No.
kailangan
Nagpa-function pa rin siya pero it's doing
impaired
it.
po. Impaired po yung function.
It's overwork. Kaya siya, like
Ay,
any other part of our body, di ba, pag overwork, lumalaki. So what does spleen do? Ano bang ginagawa niya?
Nag-filter po ng RBCs.
Yes. So our RBCs, yung blood natin, siya yung sumasala, no? Isa sa mga sumasala. Like, so if you have thalassemia, you know na iba-iba yung shape niya, right? So the more it goes, it's filtered by your spleen, mas hirap siya kasi nga hindi siya compliant, no? 'Di ba yung you learn in your anatomy, no? Yung shape ng spleen, no? And shape ng RBC when it goes inside that sieve, 'di ba? It's compliant. Pero kung sira yung shape ng RBCs mo, pagdaan niya doon sira siya. So yung spleen mo napapagod, no? So what happens? Lalong bumababa ang hemoglobin. Lalo siyang nagiging anemic, lalo na kung ang laki ng spleen mo. And it's evidence here as in your report that the blood transfusion requirement increases, no? In some reports it's 250 ml per kilo per year. So you have to compute, no, ilan yung transfusion niya na nare-receive in a year. If it's around that amount, you have to remove the spleen kasi otherwise transfuse ka ng transfuse. And based on your report, makikita mo yung side effect of transfusion, which leads me to, sino nagsabi about chelation? Somebody mentioned about chelation. Who reported on chelation? Management, treatment, mga yan. Okay, so regarding chelation, it was mentioned, si Hana, ikaw ba yun nagsabi regarding chelation? Or si, oo. So regarding chelation, what is meant here, I just want to correct, no, para hindi tayo malito. Yung concomitant, it's not, it doesn't mean you have to give the ferracirox, the ferroxamine, the feriprone all at the same time. You choose one. Kasi each chelator has its own advantage and advantages. One is oral, one is injected, one is the IV, one is cheaper, one works better when there's a heart problem or a liver problem. So you can choose. You don't give them all at the same time. Concomitant here means you give it concomitantly with other management for thalassemia. Okay, that's what it means. Okay, I just want to correct that one. All right. So, Paulo, how do we prevent stunting in thalassemia? You mentioned it in your report as one of the complications, as well as heart problem. How do we prevent the stunting and heart problem?
Ano po, Doktor? Parang ang alam ko po is to support nutrition to prevent stunting po.
Aside from that, yes, nutrition is very important. I agree.
Wait lang po.
And heart problems as well.
Sa CHF po si Doktora parang
ano bang nangyayari sa thalassemia? Anong mababa sa kanila?
Hemoglobin po.
Yes. So, according to Hannah, you have to transfuse. So what do we do?
Ano po, Doktora? To prevent CHF po. Wait lang.
Okay. So, in your report, it was mentioned that you have to maintain the hemoglobin level, no? It's also recommended to maintain around 100. Of course, you can aim for the normal level, but with the thalassemia, it's somehow very difficult, no, to attain the normal level. But if you want to prevent all these complications, no, target mo at least 100 and up. That would be good. It will already prevent, may nag-mention sa inyo also earlier, no, yung extramedullary hematopoiesis. What does that mean? Oh, si Hanan naman. Si Hanan daming sinabi eh. So, what does that mean? Extramedullary hematopoiesis. That can be prevented by maintaining the hemoglobin level at 100 and up. Before, ang target is to maintain it at 120. That's super transfusion. You transfuse until you get 120. But they saw that the complications are higher if you receive too much transfusion as well, kasi yung iron also increases. No? So now, the recommendation is to maintain it around 100. No? So, yan, ang sabi mo dito, yung extramedullary hematopoiesis, meaning, di ba, yung where is our blood formed, produced? Sabi din ng group 1 kanina. It's in where?
Bone marrow po, Doctor.
Bone marrow. So normally, it's the bone marrow that is the factory of our blood. Lahat nandyan. Pula, puti, platelet. Dyan ginagawa. Extramedullary, kasi hindi na nga kaya ng bone marrow to sustain the amount, the level of hemoglobin. So the rest of the bones in the body are recruited to produce blood. So sa thalassemia, what do you see? They have these leonine phases. No? So mukha silang leon kasi very prominent yung cheekbone, yung forehead, kasi yung cranium is one of the most common bone that would have extramedullary hematopoiesis. No? So again, by maintaining a particular blood hemoglobin level around 100, then that will be prevented, no?
Para malabas mo.
All right, so I'll go back to Hafsa. Hafsa, what is another, say for example, napanganak na si baby. Ano pa yung pwede nating gawain to detect if there's thalassemia? Because it's being done now. It's a law already. What is available in our hospitals, lying-in centers, na we can offer to the babies to detect if there are any hemoglobinopathies? Last na. It's available now. It's a screening. We do it in the NICU with after 24 hours of life ng baby. Ano ginagawa natin? Yung hinihil prick sila.
I'm not familiar with that, Doc.
Okay. So we can recommend newborn screening. Ngayon meron ng expanded newborn screening, and it is already a law, no, that all newborns should undergo expanded newborn screening. So before, yung newborn screening natin only has 5 and then became 6 diseases, congenital diseases that can be detected. But with the expanded newborn screening, it's up to 28 that can be detected. And part of that 28 is hemoglobinopathies. So sometimes, I get patients na yung baby nag-positive. So saka pa lang nalaman, yung parents positive din after kung i-work up. No, kung hindi pa na-detect si baby, hindi malalaman na meron din yung parents kasi very mild kasi ano lang sila, 1 gene or 2 gene deletions. No, so don't forget that you have to encourage everyone to get the newborn screening for their babies. Okay? Are there any more questions for the group? Thank you, group 2.
Thank you po.
Thank you.
So, yeah, we can have group 3. Thank you, group 2.
Thank you, Doctora.
Morning, everyone. Can you see the slide? Pa-confirm na lang po.
Yes.
Okay, thank you.
Um, Hello, good morning. Rinig po ba ako? Hello?
We
Yes,
can hear
Dylan.
you.
Yeah, okay, so good morning everyone. Good morning po Dr. Arca, Dr. Andres. We're group 3 and we're here to report on iron deficiency anemia with a subtitle of a common curable disease. Next slide. So just an outline on the contents of our report, and next slide will be moving forward to the introduction. So to introduce you to iron deficiency anemia, it's a condition that arises when the balance of iron intake, iron storage, and the body's loss of iron are not enough to fully support the production of red blood cells. Iron deficiency anemia rarely causes death, but it does provide a significant impact on the health of a human being. If we look at it from a societal standpoint, in developed countries, it is easily identified, and actually sometimes physicians overlook the possibility of having iron deficiency anemia. But in underdeveloped regions of the world, it still remains as a major it affects major parts of the population in underdeveloped areas of the world. And as of now, prevention and successful treatment is insufficient, especially for those underprivileged women and children. Slide. To go over the magnitude of the problem, next slide. 30 to 50% of anemia in children and other groups are caused by iron deficiency anemia, according to the World Health Organization in 2007. So because 1.6 billion people are anemic, several hundred million manifest the iron deficiency anemia. And iron deficiency is the most common cause of anemia worldwide. And as mentioned earlier, it's not evenly distributed throughout the world, and it's more prevalent in developed, or I mean underdeveloped regions of the world. It's more prevalent in young children, and in some locales, it would even be at 100% prevalence among young children. In those same underdeveloped countries or regions, 40 to 50% of the population remains anemic at all ages, with the exception of non-elderly men. Next slide. In comparison, again, the iron deficiency anemia is less of a burden in developed nations. Particularly in the study, it focused on the US, wherein the prevalence of iron deficiency anemia is reduced among all age and gender groups, with 10 million people being iron deficient, 5 million of which have iron deficiency anemia, and below is a graph just showing the distribution of prevalence of iron deficiency anemia. As you can see po, North America has only 3.4%, reflecting the fact that in developed countries, it's not as prevalent. Same with Europe, with only 16.7%, with Asia and Africa having the highest prevalence among the groups given in the graph or the table. Next slide.
Recognizing iron deficiency anemia. Next slide. Certain clinical conditions carry an increased likelihood of iron deficiency. Pregnancy, adolescence, period of rapid growth, and an intermittent history of blood loss of any kind should alert the clinicians to possible iron deficiency. Signs related to iron deficiency depended on the severity and chronicity of the anemia, in addition to usual signs of anemia, which are fatigue, pallor, and reduced exercise capacity. Signs related to IDA may include complaints of poor mental performance and cognitive dysfunction. Neurological damage is particularly relevant in infancy brain development, where long-lasting cognitive challenges occur despite therapy later in life. Therefore, IDA during infancy should be aggressively treated to avoid the potential for cognitive problems. Next is cold intolerance, which develops in 1/5 of patients with chronic IDA and is manifested by vasomotor disturbances, neurologic pain, or numbness and tingling. Fatigue and exercise-associated dyspnea are regularly reported. IDA diminished work performance for forcing muscles to depend on anaerobic metabolism to a greater extent than they do in healthy individuals. Chelosis and koilonychia, signs of advanced tissue iron deficiency. These are defects in structures and function of epithelial tissues that may observe in iron deficiency, where fingers may become brittle or longitudinal in shape. Thus, it can be seen as a spoon-shaped nails. The tongue may show atrophy of lingual papillae and develop a smooth appearance of glossitis or inflammation of the tongue. Angular stomatitis may also occur with fissures at the corner of the mouth called chelosis. IDA is associated with rather striking neurological conditions, and in some patients, restless leg syndrome is shown to be prevalent in pregnant women and is recognized as a reversible symptom for reduced brain iron levels. Another neurologic condition that is prevalent in Africa that is called pica. It is defined as a dietary compulsion of materials that are not usually eaten by humans. Geophagia, or deliberate consumption of earth, soil, clay, have been reported in this area. Next slide. The diagnosis of IDA is typically based on laboratory results. Laboratory evaluation reveals characteristic changes in blood parameters for iron regulation, storage, transport, and utilization. Currently, the central parameter based on the journal is a significant iron deficiency that is seen in ferritin, which acts as a storage for iron. Under steady-state condition, the serum ferritin level correlates to total body iron stores. Thus, the serum ferritin level is the most convenient laboratory test to estimate iron stores, where the normal value seen in adult males is 100 micrograms per liter, while in females, averaging 30 micrograms per liter. As iron stores depleted, the serum ferritin falls to less than 15 micrograms per liter. And 15 micrograms or less is a diagnostic for iron deficiency and correlates specifically with the absence of stainable bone marrow iron. Hepcidin is the main regulator for iron in humans, and research studies suggest that low or absent hepcidin levels may be diagnostic or of simple iron deficiency. Lastly, iron absorbed from the diet and released from the stores circulates in the plasma bound to transferrin, a iron transport protein. Transferrin protein expression increases in iron deficient states where body tries to compensate for low iron levels. So the saturation of transferrin is reduced to values of less than 15%. The following results are expected in a CBC of a patient with IDA. Increase red cell distribution width, decreased RBC count, decreased RBC hemoglobin, which is due to reduce hemoglobin production and may be useful for screening infants and children with IDA. Decrease mean cell volume, decrease hematocrit level, unless the iron deficiency is reversed, the hemoglobin and hematocrit levels decrease to sufficient low levels to be classified as anemia. Next. Moving on to the major causes of IDA, blood loss is one of the most common physiologic mechanisms causing IDA. Blood contains iron within the red blood cells. For each milliliter of packed RBC contains estimated 1 milligram of iron. Each day, 1 milligram of iron is absorbed from the diet, and 20 milligram of iron from senescent erythrocytes are available to support for erythropoiesis. Hemorrhage is one of the most common excessive loss of body iron, but it can occur with hemoglobinuria from intravascular hemolysis. Hemorrhage decreases the host red cell mass, decreases the blood supply, and increases the iron demand for erythropoiesis. Chronic blood loss from menstruation or from parasitic infections like hookworm has the greatest impact worldwide. Women with heavy periods at the risk of iron deficiency because they lose blood during menstruation. Gastrointestinal bleeding, blood donation, nosebleeds. Gastrointestinal bleeding can result from regular use of OTC pain relievers such as aspirin. And intravascular hemolysis with hemoglobinuria, which occurs in malaria, also results in iron loss in the absence of hemorrhage, will be further discussed.
Good morning, Dr. Andres. Good morning, Dr. Arca. There are four more major causes of IDA, and I will be discussing the next two. So another cause is maternal fetal bridge of iron deficiency. Requirements for iron are greatest around the time of birth. During pregnancy, it is estimated that 1,200 milligrams of iron is required from conception through delivery. Iron intake and stores in the mother must satisfy fetal development and blood loss at delivery. Additionally, the maternal erythrocyte mass should increase from 350 to 450 ml. By comparison, pregnant women without iron supplements only increase their red cell mass by 180 to 250 ml. One interpretation of this difference is that fetal iron demands are prioritized over the red cell mass of the mother. Postpartum, iron is lost as lactoferrin in breast milk. Those losses are balanced by the absence of menstruation in the lactating female. Next. Another cause of IDA is malaria. Iron deficiency anemia and malaria coexist in most tropical regions of the world. Malaria contributes to iron deficiency anemia by causing intravascular hemolysis with subsequent loss of hemoglobin iron in the urine. This clinical feature was described in 1898 as black water fever. Malaria also causes an immune response that suppresses erythropoietin, as well as direct effects on erythropoiesis. The host may also increase hepcidin expression for protection from liver stage malaria, and increased hepcidin restricts iron and might delay erythroid recovery.
Another major cause of IDA is hookworm. There are two common hookworms normally found in humans, Negator americanus and Ancylostoma duodenale. These hookworms may be acquired by walking barefoot on contaminated soil, like they penetrate the skin of your foot, and by ingestion. Now, hookworms lives on 0.3 to 0.5 ml of blood. Now, adult hookworms lay lay 10,000 to 30,000 eggs in its lifespan. Now, adult hookworms lives usually normally for 1 to 2 years. Now, heavily infected patients are simply unable to maintain adequate iron stores and becomes anemic. Now, for the treatment, kahit antihelmintic drugs lang can cause the reversal of IDA. Next slide, please. Uh, another major cause is diet and malabsorption of iron. Now, sa diet, malnourishment is common sa underprivileged women and children, just like discussed sa introduction. Now, treatment lang dito is eating meat, eggs, and leafy green vegetables. Now, yung additional iron in the diet may be required sa patients with blood loss, rapid growth during infancy, malaria, and hookworm. Now, sa malabsorption of iron is common after some forms of gastrointestinal surgeries. Infections, inflammation, and other hepcidin upregulating mechanisms are likely to inhibit non-heme iron absorption despite high availability of iron in the diet. Uh, Another treatment is vitamin C. Taking vitamin C in the in the diet for to improve the absorption of iron. Next slide, please.
Okay, so solving the global problem on IDA. So there are three that we identified here, one of which is iron fortification. So iron fortification remains the mainstay of efforts aimed toward the treatment or prevention of IDA or iron deficiency anemia, of which is multiple micronutrients to reduce anemia in school children, as an example. So this uh, provides improving iron, riboflavin, RBC, folic acid, and vitamin A levels. Another is in-home food preparations with iron supplements. So example given in the journal is supplementation of iron in wheat flour. It has been fortified with iron in Canada, UK, and in United States. So here in the Philippines, one example is yung fortification of iron in our rice. Yeah. So another is oral preparations and dosing regimens for menstruating and pregnant women. So intermittent iron supplementation lessen adverse effects such as nausea, constipation, and teeth staining. And another is intravenous iron preparations should continue only until anemia is resolved. So these goals are met with a normal hematocrit and serum ferritin level of 50 to 100 micrograms per liter, corresponding to 400 to 800 milligrams of iron in stores for otherwise healthy adults. Another prevention is delayed clamping of umbilical cord. So a delay of 5 minutes results in 166 milliliters of added blood volume for a 3.5 kilogram infants. So what they do is placental transfusion is also achieved by placing the newborn on the mother's abdomen after vaginal delivery and clamping the cord once it stops pulsating. In cases of a cesarean section or other clinical setting that may preclude delayed clamping, clamping near the placenta should increase the volume of blood delivered to the newborn. Widespread adaptation placental transfusion may have been prevented to date by unsupported concerns for polycythemia, hyperbilirubinemia, and increased blood viscosity. And neonatal anemia and iron parameters by 4 months of age were improved, and none of the infants who had undergone delayed clamping had ferritin levels below 20 micrograms per liter, versus decreased ferritin levels in 7.4% of subjects who had undergone clamping almost immediately after delivery.
So the last part for solving the global problem would be researches. It is said that advanced global therapy for iron deficiency anemia will be greatly assisted by basic research. So first off would be hepcidin biology. The recognition of hepcidin expression is highly variable and influenced by circadian rhythm and should be advantageous in improving dosing regimens. While the kinetics for hepcidin expression remains unexplored, thus this opens a research avenue toward the optimization of this kind of therapy. Now, next would be inherited hemochromatosis. Inherited hemochromatosis causes your body to absorb too much iron from the food you eat, and the excess iron is stored in your organs, especially in your liver, heart, and pancreas. Uh, Next would be thalassemia. Thalassemia has a more direct relationship with iron deficiency anemia, and patients that is diagnosed with thalassemia with microcytosis is similar to iron deficiency. This is because both diseases are concentrated within malaria and hookworm endemic regions of the world. Um, Next slide. Uh, Next would be the TMPRSS6, which is a recent gene discovery that helps in regulation of iron. Um, so discovery for this gene can mutation of this gene can cause iron deficiency, and then further research into the complex relationship between deprivation of iron for this pathogen and iron deficiency anemia are still needed. Thus, the determination of hookworm effects on hepcidin expressions um, can be also pursued for further research, and the relationship between hookworm and intestinal iron absorption can be studied further and understood and incorporated into the eradication of iron deficiency anemia. Next slide, please. So for the conclusion, the diagnosis and treatment of iron deficiency anemia is achievable in most, if not all, individuals, while consideration of iron deficiency anemia must include the possible convergence of the several causative factors, such as yung hookworm and yung hookworm. And then more communal approaches are being taken to overcome the overlapping causes of iron deficiency anemia that affects hundreds of millions worldwide. And increased research and understanding of fundamental iron biology will assist in devising new strategies aimed toward the global elimination of this disease. So that's all.
Thank you, Group 3. Dr. Andres, do you have question for Group 3? Okay.
Iron deficiency anemia, one of the more common conditions that you will encounter. And any anemia, as Dr. Arca would surely say, always rule out IDA first before you consider other anemia conditions. Okay. Especially for pregnant patients, it's one of the things that you must be on the lookout for always. And it's getting better because we are getting more options for treating anemia or iron deficiency. However, as a culture, we really lack in getting enough nutrients. We are not very fond of drinking milk. We are not very fond of eating fish, etc., etc. Hence, even it, well, maybe blame it on a Western diet, diba? Nutritional deficiency would be quite common, and iron deficiency would be one of the collateral damage for such.
Thank you, Dr. Andres. Yeah, I do agree very much. So Dylan you mentioned earlier na compared to high-income countries, us in the low-income countries would have, based on your study, in your report, in your paper, is there a difference in the number of IDA patients in HICs versus to LICs, Dylan? I mean, high-income country meaning the first world countries, and low-income countries, the so-called third world or developing countries.
Yes, po, Doc, there would be a difference po, or a gap between identification and treatment po, because in HICs po, higher income countries, based on dun po sa table kanina, Europe and North America belong to this group po, and they had respectively 3.4% and 16.7% prevalence among infants and young children. Whereas with Africa and Asia, known to be third world or LIC regions, they're a bit on the higher end of the prevalence po.
Yeah, maybe because yung nutritional aspect din, no? Availability of food, as Dr. Andres mentioned, no? Mas maraming hindi nakakakain ng sapat in the lower income countries. So, but Dylan, what would be what age group would IDA be more commonly found? Can you turn on your camera so we can see you report? Can everybody turn on their camera so makita namin kayo? Yan. Yan. Hello, everyone.
Yes, good morning po. It would be more common po from children newborns to 5 years of age po, based on the study.
More of the 3 to 5 years, no? Kasi, yeah, of course, syempre, sa newborn, they have yung iron from the parents, but after several months, no, magwe-wane na yung levels that they have. So you have to supplement them also. But for the 3 to 5, kasi ito na yung mga picky eaters, no? So, and what would be the most common cause of iron deficiency anemia? Anybody from the group? What's the most common cause?
Yung diet po, Doc. Yung less meat po, yung mga eggs and vegetables po.
Yeah, I agree, Dan. So it's more of nutritional, no? Yung problem, inadequate nutrition. So that leads to the IDA. Correct. All right. So Aleli, you showed the labs that we can request, no, to detect or to check for iron deficiency anemia. So among, 'di ba, kanina sa group 2 we mentioned yung mga red cell indices, no? Balik ulit tayo doon kasi related sila with thalassemia. So with the IDA, with regards to the red cell indices as mentioned earlier, no, yung MCV, MCH, MCH, CRDW, which among those red cell indices would manifest first? Would you see the changes first when your patient would have iron deficiency anemia? Have you come across it in your report?
I think it's MCV po. Or ano po, RBC hemoglobin. Hematocrit levels.
No. Red cell indices, meaning the MCV, MCH, MCHC, RDW.
Hemoglobin.
No, that's not part of the indices. That's part of the CBC result. So dun sa RBC indices, okay, so that you know, that part of the CBC, it describes your red blood cells, right? Oo, di ba nasa report mo yun? So MCV, as mentioned by group 2, no, MCV would give you the size of the red blood cell. Maliliit ba siya, malalaki ba siya, o normal ba siya? MCH will give you what? The color, di ba? Mentioned kanina, the color. Maputla ba yung red blood cell mo o tama lang? No? So medyo subjective when you look under the microscope, but when you look at the CBC result, it's automated, di ba? So yung machine, yung nagde-detect. Then MCHC, you see the hydration of your red blood cells, no? Like for spherocytosis, bilog na bilog, punong-puno ng fluid sa loob, akala mo puputok, no? Or sa mga thalassemia, parang dehydrated yung RBCs mo. Okay? And then the RDW is the red cell distribution width. It gives you the differences in the sizes of your red blood cells. No? So kung mataas yung RDW mo, ibig sabihin meron kang normal size, may malaking size, may maliit. So among those 4 parameters, which do you think would manifest first, would change first when you have IDA? Trivia lang. Tatanong namin sa exam ni Dr. Andres. So sa yung mga hindi nakinig, di nila malalaman sagot.
Yung color po.
Color. Sabi ni Aleli. Hindi. Oh, 3 na lang natitira. Hindi yung color.
Yung size po.
Oh, hindi rin yung MCV. O, 2 na lang. Oh, ilan na lang natitira? MCHC at saka RDW. Kaya 50% chance nang tumama sa exam. Dali nang makakain na tayo. Game.
Shape.
Shape. Shape?
Shape po.
Poikilocytosis? Wala naman doon. Yung MCHC, yung hydration. Yung RDW changes, differences in size. Oh, dali. 2 na lang yung choices. Patrick, sagutin mo na nga. Sino ba reporter kanina? Francis. Dan.
Ano po, Doc?
Syra.
RDW po.
Ay, tumama din. Okay, o sa'yo yun ang sagot ha. So you'll see first, it's the first manifestation. So syempre, your body, your bone marrow will try to compensate for the anemia, right? So it will try to produce RBCs. And sometimes, kaya makikita mo may differences ng size, baby pa yung red blood cell, nilalabas na niya from the bone marrow. Kasi nga, anemic ka na gusto niya makompensate. So, you'll see the changes first in the RDW, tataas siya. Kasi napuproduce na yung, lumalabas na yung malalaki, may maliliit, no? So, RDW is the first manifestation. Okay. So, okay, are there any medical concerns that would affect also IDA or level of ions in our body? Dan Joseph?
Ano po, mga infections po like peptic ulcers po and inflammation po like yung inflammatory bowel disease po.
Mm-hmm. Because why would it affect your iron levels?
Beta-block niya po yung ini-inhibit niya po yung kasi po yung epithelial tissues dun po sa duodenum and po yung jejunum. Nabablock po yung passing through ng hepsin, tama po ba?
Hepcidin.
Hepsinin po, nabablock po. So hindi po nakapag-transport ng iron from the small intestine to the plasma po.
Okay. So yung absorption is mainly affected. No, Francis, ito. So can you tell us ulit, just shortly, no, ano yung benefits of delayed clamping for the newborns?
The benefits po ng delayed clamping is to promote po yung transfer ng iron from the mother to the baby. So it will increase yung hemoglobin levels of the baby and improves yung iron stores po.
Are there any complications with the based on your report, based on your readings, no? Are there any complications associated with delayed clamping? Pasensya ka na, OB at saka pedia yung proctor nyo ngayon eh.
Siguro po, Doc, hindi ko po nabasa pero based on my understanding kung may decrease of levels ng hemoglobin transfer.
Decreased kanino? Ay, decreased
from the mother going to the baby.
Delayed clamping. Di ba dumadami nga yung pumupunta sa baby? Ganun ba yun? Tama ba, Dr. Andres? Tanong tayo sa OB.
There could be complications po as I understand po kung there would be a decrease po. So, mas ma-prevent po yung decrease nung transfer ko if we would delay in such time, parang 5 minutes. Based po dun sa nabasa ko, ganun.
Agree ka ba dun?
May
Parang
early cord clamping nga, di
kaya
ba? Ang newborn care mo is early cord clamping. So, would the iron store, going back to Dr. Arca's question, would the iron stores be significant if you delay cord clamping?
Yes po, Doc.
Parang testmanship, di ba? May early cord clamping ang recommendation ngayon. That is with the essential newborn care. So what would the study show for delayed cord clamping and early cord clamping as far as iron stores are concerned? Transfer of iron stores. Diba sa delayed cord clamping, what you do, you milk from the umbilical cord towards the baby so
Towards the
that
baby po, Doc.
you will have more blood. Would that procedure significantly increase hemoglobin levels of your baby?
Yes po, Doc. Yes po.
Okay.
Okay, sige. Patawarin na natin si Francis.
Okay lang.
Ano kaya naging, nabasa ko po kasi yes. Pero inuunawa ko po kung paano magiging no.
So, inuuna.
Okay. Sige, tanungin naman natin si Syra. Meron ba ako hindi natawag sa inyo? So how will we, kasi di ba dun sa report nyo and the report ng group 2, parang yung IDA and thalassemia are closely related eh. And I would agree, no, it's sometimes very hard to differentiate the two. But how will we differentiate them, Syra? Syra ba? Syra.
Syra po. Ay, dito po. Yung thalassemia po is mutations po sa globin genes na nagde-decrease ng production ng hemoglobin. Then yung iron deficiency po is mababa po yung iron level. Hindi po nakapag-bind yung iron sa hemoglobin ng RBC.
But in the patient, kunyari, without the genetic tests, paano mo sila i-separate from one another? Anong pwede, based sa report nyo, nandyan sa report nyo. So, paano natin, masiseparate sila?
Mas mababa po yung RBC count ng iron deficient na patient.
Pwedeng pareho sila eh. Halos kasi when you look at the labs, halos pareho sila except that yung reticulocyte count ng thalassemia mas mataas. Sa iron deficiency, it can be normal or low. Ano pang way? Well, you're correct naman, no? So of course, may genetic basis ang thalassemia. Sa iron, syempre nutritional yung most common na cause. What else? In terms of treatment, ayan, sige, sino ba nagsabi ng, si Dan Joseph ulit yung mga treatment, no? Tsaka si Francis. Oo, si Francis pala, iron fortification. Sige, kunwari, may IDA patient ka, hindi mo alam, thalassemia ba to IDA? Then, in-iron supplement mo. Paano mo masasabi? Okay, iron deficiency nga to, hindi to thalassemia. Francis. Si Francis ulit, bigyan natin ng chance si Francis.
Paano masasabing iron deficient po? Siguro after po the diagnostic test. Tama po ba?
Mhm. Pero pag sa
Ah,
CBC, halos pareho nga sila ng itsura.
So
Mahirap, no?
sa signs and symptoms na manifest.
Halos pareho din
Parehas din.
manifestation nila at the early stages. Oo. So you give iron supplement also, and then what?
And then check po ulit.
Oo. And then kung na-check mo, anong titingnan mo? Tingnan mo kung nag-respond.
Yeah.
Oo. Kasi
Kung
giving
nag-increase or
your
decrease.
magdi-decrease pa, nagbigay
Ay,
ka na
increase
nga.
or yeah.
O hindi
Nag-improve pala, I mean.
tumaas. O hindi nag-improve. Si Francis talaga. O, kulang sa breakfast. Oo. Kasi...
Let me
sige, go
change
ahead.
the clamping. Okay, they changed it to properly time the cord clamping. So yung delayed, you will not as long as it's within 1 to 3 minutes. Okay, it would be of benefit. So not longer than 3 minutes. The early is within 60 seconds of life. Okay, so tinanggal na yung early at delayed kasi nga maraming issues. So, ang bagong nakasulat sa Essential Newborn Care, I just checked, would be properly timed cord clamping.
Thank you, Doc Andres. Well noted.
Delayed pa din to an effect, pero hindi yung iba kasi sobrang delayed na ang tagal. And you delay newborn care, that's important as well. Yung iba naman, cut agad. But again, if your baby's asphyxiated, you cut and do resuscitative measures immediately. So within 1 to 3 minutes of clamping, okay, so that you won't forget.
1 to 3 minutes. Okay,
1 to 3
Sorry,
minutes.
medyo nawala
Thank
ako.
you, Doc.
Drops vitalis ako. Kakasend lang ng patient.
Oh no!
Nakakaiyak.
Ayan na nga, tamang-tama ang report nila.
Ako minulto ng report. 27 weeker na. May eye drops pa lumabas yung ultrasound.
Oh, wawa.
Pero may heartbeat kaya wala akong magagawa pa.
Oh. 20
Ay, nako,
weeks.
sige. 20
Good
weeks.
luck.
Good luck sa akin.
Oo nga. Ayan, pa-reportin
Sakit sa
ulit
box.
natin sila. Kaya pala pinag-report sila ng high drops. Oo. So going back no, dun sa iron supplementation, it can be both diagnostic and therapeutic. Siyempre, ang goal mo is gamutin yung iron deficiency. So kaya ka nagbibigay, no? Why is it diagnostic? Kasi, you know, that tingnan nyo sa book nyo sa Nelson's, there's a table there that shows you yung reaction ng bone marrow, yung response ng body with regards to iron deficiency. No? So for after a week or so, may a few days, may reticulocytosis ka na. After a month, you will see a hemoglobin level that's almost leveling up to normal. No, so if you monitor closely your patient and you see na nag-improve yung iron, no, so say kunwari hindi nyo na pa iron levels. Siyempre iba na, alam na agad pagka serum ferritin nyo, alam nyo na agad na mababa yung iron, right? Although there is very few instances na ang thalassemia pwede ring magka-iron deficiency. Very, very rare kasi nga nag-accumulate ang iron sa kanila. So, with that, with this patient na hindi naman siya thalassemia, hindi pa diagnosed of anything, no? So, you treat the patient, you monitor, you check again your levels. If the patient improves, then most likely it is an IDA. But if you've been giving your iron already and the patient still not improves, then you have to investigate further. Baka mali yung diagnosis. Baka there is something else that causing the anemia and not really the IDA. Because I have had patients like that. Isang taon na mahigit naka-iron supplement, anemic pa din. So, tapos when we worked up the patient, thalassemia pala. So, kaya pala hindi nag-i-improve. No? So, check your diagnosis again if that happens. Okay, so any more questions for the group? Thank you, Dr. Andres, for the update sa EINC. Mas politically correct nga naman yung ano yun, timely, ang tawag? Sorry. Properly timed. Oo, clamping, yes. Mas politically correct. But the magic number is 1 to 3 minutes.
So, Arca, ano nga ang condition yung kahit mababa ang hemoglobin, you are not to transfuse? Alala. Di ba may ganon?
It depends kung gaano siya kababa. Kasi nga kung symptomatic siya, then you have to give kasi nga magko-compensate yung body mo, masisira yung heart, yung ibang body organs will be compensated also. So, ano ba? Yung hindi tinatransfuse.
Meron bang ganon? Parang meron akong
Oo. Pero ganito, kasi pag severe, like for example, severe thalassemia, sanay sila na ang baba ng hemoglobin. Ang pinakamababang nakita ko na thalassemia major, hemoglobin niya 3 lang. Imagine.
So, hindi talaga siya tataas.
3 lang kasi pero katatransfuse lang noon the previous
Lalakad
month.
yun?
Oo, buhay. Tapos nasa ER. Pero kasi ayun, so 3, so talagang pag tiningnan mo yung heart, ang laki na nung heart, no? Talagang tapos makita mo talaga yung buto niya very prominent na, no? So pero eventually that patient died kasi bumigay na yung heart, no? So when you have patients who are chronically anemic, you don't bring up the hemoglobin fast, no? So you transfuse slowly kasi magko-congest, no? So 'di ba usually binibigay natin 10 cc per kilo na pack RBC. Dito you can start as low as 3 cc per kilo or 5, and then pagka medyo tumaas ng konti, 5 cc per kilo, and then you up again, no? Until ma-achieve mo yung gusto mo na level. Pero you don't transfuse 10 cc per kilo agad kasi magko-congest talaga. Ano yung lungs nila, magtutubig ang lungs kasi sanay na sanay yung katawan nila na ang baba na ng hemoglobin level. Napaka-unfortunate noon kasi magkakapatid sila 4, lahat sila major. So sobrang, sabi sa PGH, magkakapatid sila na so barkadahan sila pag na-admit, 3 or 4 nandun sa ER nagpapatransfuse. So sobrang kawawa din yung parents. No, so that's why it's important, no, to refer them also to genetic counseling. Kasi kung ganun, then you really have to explain to them na ito yung scenario that will happen. No, if you had many babies na lahat sila ay major, talagang kailangan mo ng blood bank. Kawawa din. Okay, so thank you very much for the interesting reports, no, and for the inputs.
Could you open your camera so we could document? Justly, could you please send us your PowerPoint presentations?
Si Justly ba ang LO?
Si Justly.
Okay.
Aleli, Hafsa, MJ.
Smile, 1, 2, 3.
Hindi umabot si Hafsa. Hafsa.
Again po.
Doc, I can't open po kasi nagpa-prepare po ako para pumuntang school. May 1 p.m. po kasi kami, so medyo malayo po ang bahay ko.
Okay,
sige.
Ingat.
Sorry po.
Okay, sige. Thank you, everyone.
Okay, you may be
Thank you po, Doc.
Thank you po.
Thank you, Doc.
Ingat kayo.
Thank you po.
Thank you, Doc.
Thank you po.
Thank you po.